ventriculostomy and made by the Fogarty catheter. Anteriorly, we had the tuber cinerem and posteriorly the mammillary body. Now, endoscopic view of the cavity floor of the third ventricle. Anteriorly, as we can see, there is optic chiasma, the membrane of the floor of the third ventricle, and posteriorly we have the mammillary bodies. Now, in this section, where this is the same view, the inferior view of the floor of the third ventricle. We can see the close relationship of the posterior part of the circle of Willis with the third ventricle. At the level of the optic chiasma, we have the carotid artery, and posterior to mammillary body, we have the basilar artery and the posterior communicating artery, and from the posterior communicating artery arising from the thalamoperforator, supplying the posterior part of the floor of third ventricle, and hence giving a perforated appearance, so called the posterior perforated substance. Again, the cavity of the third ventricle, but the midbrain and the floor has been completely removed. Here we can appreciate the pituitary stalk, infundibulum. This is the lamina terminalis that form the part of anterior wall, anterior commissure, column of the fornix. The green color structure is the foramen of Monro, the interthalamic adhesion or the massa intermedia, and the tilia choroida, and posteriorly we have the posterior commissure.
Sorry, Rafay, could you describe this again, please, just and go slow?
Sir, this is the inferior view of the cavity of the third ventricle, but the floor has been completely removed and the midbrain has been removed. So we can view the cavity from the below, and anteriorly we have the pituitary stalk and the infundibulum. Here is the pituitary stalk and the infundibulum. This is the lamina terminalis, the anterior wall of the third ventricle. Posterior to it, we have the anterior commissure and the column of the fornix. These green color structures are the foramen of Monro. And posterior to it, we have the massa intermedia, that is the interthalamic adhesion. And posteriorly, we have the posterior commissure. And in between these two, we can appreciate the velum interpositum and containing the tila choroida and the vessels. Now, the anterior wall. The anterior wall of the third ventricle is marked here as in red, which is formed by the optic chiasm inferiorly. The upper part of the anterior wall is hidden by the rostrum of the corpus callosum. From the optic chiasm, a membranous structure arises, that is the lamina terminalis, and that goes upward and blends with the rostrum of the corpus callosum. And we have the anterior commissure posterior to the lamina terminalis, and on the anterior superior wall of the anterior wall of the third ventricle, we have the foramen of Monro. This is the lateral view or the sagittal view of the specimen, showing the anterior components of the anterior wall, that is the optic chiasm, the lamina terminalis arising from the optic chiasm and goes upward and blends with the rostrum of the corpus callosum. Posterior to the lamina terminalis, we have the anterior commissure, and posterior to that, we have the column of the fornix, that is the continuation of the body of the fornix, and it goes and ends in the mammillary body. This is the anterior view of the anterior wall, but the lamina terminalis has been removed. These are the optic nerve, optic chiasm, and we can appreciate the cavity of the third ventricle. On the floor, we can appreciate the mammillary bodies and the aqueduct of Sylvius. Note that the close proximity of the anterior cerebral artery with the anterior wall of the third ventricle or the lamina terminalis. This is again the anterior view of the anterior wall of third ventricle, showing the membranous lamina terminalis and the close proximity of the anterior cerebral artery supplying the anterior wall with the perforated branches. This is the endoscopic view of the foramen of Monro. It is basically a crescent shape structure when the hydrocephalus is not present, and in the presence of hydrocephalus, it's become more enlarged and rounded in shape. And at the anterior superior margin, there is a junction of the fornix body and the column, and it's on its posterior margin we have the thalamus. This is the cavity, again the cavity of the third ventricle, a view through the foramen of Monro. This yellow highlighted structure is the fornix. Posterior to it we have the anterior commissure. This is the optic chiasm. The space above the optic chiasm is the supraoptic recess, and the below is the infundibular recess, and here we have the mammillary bodies. Now, the posterior wall, here we can appreciate the yellow color structure. These structures form the posterior wall of the third ventricle. That includes the pineal region, the habenular commissure, posterior commissure, and the aqueduct of Sylvius. This is the sagittal section of the specimen, showing the components of the posterior wall. This is the pineal body that is attached with the stalk. At the upper lamina of the stalk, we have the habenular commissure, and at the level of the lower lamina, we have the posterior commissure. And below that, we have a triangular shaped duct called the aqueduct of Sylvius. Again, the superior view of the cavity of the third ventricle, the body of the fornix has been removed, and here we can appreciate the components of the posterior wall of the third ventricle, that is the pineal region, the habenular commissure, pineal recess, posterior commissure, and aqueduct of Sylvius. Now, the last is the lateral wall. It is basically hidden behind the cortical surfaces, and it is formed by the thalamus and the hypothalamus and separated by the hypothalamic sulcus. The two thalamus, as we have already discussed, is connected with the band of the fiber called the massa intermedia or the internal thalamic adhesion. This is the lateral view of the specimen, where we can appreciate the lateral wall, the thalamus and the hypothalamus. And the lateral wall of the third ventricle resembles the lateral view of a bird with an open beak. Here you can appreciate the upper part of the beak is formed by the suprachiasmatic recess, and the lower part of the beak is formed by the infundibular recess, and most of the head is formed by the thalamus. Sir, any comments so far? Would you like to
No,
add
I
something?
think no, I think that you know, this is a great anatomy talk. I think you know, at some point I'd like to just make some points about the endoscopic anatomy and some other things. But I guess one thing would be that, you know, you showed the view of the endoscopic view of the mammillary bodies,
Yes, sir.
and that when we make an endoscopic third ventriculostomy, we go anterior to mammillary bodies. I think one of the key things is to focus on this midline anatomy. You know, the paramedian anatomy starts to become more complicated, but almost all the things that we do in the third ventricle tend to be along the midline. So if we look at the midline, you know, there's a lot of individual variability between the space anterior to the mammillary bodies and posterior to the clivus. This is like, you know, obviously an ideal example where the floor is translucent here. Most often this isn't the case. So things that you can do to be more certain that you're going to have success in your endoscopic third ventriculostomy is, number one, to plan well. So using navigation, I think, is very, very helpful. It's not mandatory. You can still use craniometric landmarks. And I think it's important for two reasons. The trajectory that you take through the foramen of Monro to get to the point in the floor of the third ventricle where you want to make the opening, that trajectory is very important. That minimizes retraction on the fornix and also and minimizes retraction on the veins. Because if you don't, you can optimize that trajectory in order to minimize that. On the flip side, if you don't plan for that and just use a standard craniometric landmark like Coker's point or something like that, the individual anatomy may hamper your ability to make the hole in the third ventriculostomy without retracting the fornix or without retracting the veins, which can result in bleeding, as we all know. So if we go in the midline, you've covered the chiasmatic recess, infundibular recess. This ability to see the clivus through the floor of the third ventricle is often quite difficult. However, you can palpate it. And so that's, I think, very, very helpful. You take a blunt instrument of some sort, like the Bugbee wire or something, to actually palpate the clivus. And there's a quote unquote cookie cutter technique that you can use when the interval between the clivus and the basilar is very, very narrow. You can initially make your opening right on the clivus. So I don't do that routinely, but in cases where that interval is very, very narrow, that is a very, very good strategy for making a safe opening in the floor of the third ventricle. The other thing is that we don't often venture posterior to the mammillary bodies because that's the territory of the posterior perforated substance. There is a nucleus there that is inconsequential, but depending on the pathology, so just this week, actually, and I'm not advocating that you do this routinely, but I went through the posterior perforated substance to fenestrate a arachnoid cyst that was below the floor of the third ventricle. And that interval was wide, like the cyst had widened it by a centimeter and a half. I don't have the edited video, otherwise I would show you, but it's, unless the pathology significantly altered the normal anatomy, that is not an area to venture in, the posterior perforated substance. It will bleed and the bleeding will have consequences. So that's the reason for not getting lost in this area. Sorry to take up so much time.
Yes. Okay. Now for a quick revision of for the residents, I will ask some questions. No.
The other important point, sorry, one other last thing is that are you going to cover the venous anatomy here again or no? You showed that posterior third ventricle and the internal cerebral veins some.
Sir, I have already discussed about the internal cerebral vein.
Yeah, so the key thing about the internal cerebral veins, in my opinion, is that if you take the thalamostriate vein or the septal vein, usually things are okay. Yeah. The internal cerebral vein is not so forgiving. There's two main issues that come in: a unilateral injury to the vein or bilateral. And this can be from retraction or from coagulation or avulsion. Avulsion is the most concerning thing because if it avulses posteriorly, then you're going to end up with a lot of bleeding as the two veins join together to form Galen as Rosenthal joins with it. If you have a bilateral internal cerebral vein injury, there's a decent chance your patient may never wake up again because of the venous drainage issues. So this vein is to be handled with the utmost respect, and it's really crucial to keep that vein patent. People may anecdotally say, well, you can take one without much problem, and that's probably true. But I would not get in the routine habit of doing that because if you inadvertently somehow the other one is injured, it's a problem. Thrombosis is another issue. So if you're taking out a tumor that involves third ventricle or a glioma that is extending into the ventricular system, you can end up with a situation where there's thrombosis. You didn't intentionally coagulate the internal cerebral veins, but thrombus started to develop, and that thrombus can propagate. And then, obviously, right after surgery, you cannot anticoagulate these patients, and that's a problem as well. So, the internal cerebral veins here are key and crucial, and they need to be preserved.
The other thing I just wanted to mention that I'm sure Azam can speak about as well is, just in terms of preoperative assessment, depending on the pathology, of tumors or anything else located in the third ventricle is the venous angle. And something just to note is that, the venous angle, as we know, is the junction between the lamellar striate and the internal cerebral vein, and oftentimes that occurs right at the posterior margin of the foramen of Monro, and sometimes it can occur even more posterior, and that's called the false angle, and in those cases that can be sort of utilized in terms of the approach, a transchoroidal approach into the third ventricle, and you can take advantage of that through the choroidal fissure. Just something to note as well.
Yeah, I love that for transforaminal approaches to the third ventricle where the pathology is more anterior. In general, that's a great approach. And that false angle can be, in many cases, you might get lucky and it's quite posterior. And so that's one of the key things that I look at when planning the transforaminal approach, is that venous angle can be opened further, or the foramen can be opened further posteriorly. Good point.
Thank you for the comment, sir. We'll move forward, and
you were going to ask questions.
Yes.
Rafay.
Now, this is for the revision of the resident, and any resident can answer. Can anyone identify this yellow highlighted structure?
Please raise your hands and we'll switch on your mic. Okay.
Dr. Tay said choroid plexus.
Parvit Kumar is there?
Yeah, sir, it is telachoroidea.
Yes.
Structure.
Yes,
It
this is the telachoroidea, and but it also has the choroid plexus along with it.
Yeah.
Achha. And next one, can anyone identify the structure marked with that black arrow?
That's the body.
Go ahead.
That's the body of fornix.
Yes, that is the body of the fornix.
Very good.
Yeah, correct. The next one, can anyone identify this triangular area highlighted with yellow and its significance?
We have a lot of votes for velum interpositum.
Yes, absolutely correct. This is the velum interpositum. Can anyone tell about the significance of this space?
Ahmad, can we unmute somebody?
Any answers?
Velum.
Parvit Kumar is online.
Velum interpositum, it is superficially, it is the fornix, then the telachoroidea upper layer, and the lower border, it is by the lower border of telachoroidea, and it will be form this roof of the third ventricle, and it enclose the vascular structures.
Yes, it includes the vascular structure in it. Correct. The next one is identify this blue colored vessel. Name this vessel.
Internal cerebral vein.
Internal cerebral vein.
Okay, server.
It's internal cerebral vein, sir.
Yes, and how does this form? Anyone else?
Okay, Ali.
It is formed by thylamostriaty and septal vein.
Yes,
they
it
combine
is formed,
together and they form the internal cerebral vein.
Correct. It is formed by the thylamostriate and the septal vein. Next is the endoscopic view identify this yellow colored highlighted structure.
Hello.
Dr. Rupesh.
Yeah, that's optic chiasm.
Yes, correct. That's optic chiasm. This is basically the view of the cavity of third ventricle through the foramen of Monro, and this is the optic chiasm, and superiorly this space is the suprachiasmatic recess. Now, the next one, anyone tell the significance of this area, the clinical significance of this area, I'll mark with the yellow arrow.
Dr. Pravat Kumar again.
It is the space for the third endoscopic third ventriculostomy. Through this
Yes.
area, we are doing the third ventriculostomy.
Yes, this is the floor of the third ventricle, and this is the area where we make a hole during the ventriculostomy. Correct. Now, a question: post ETV, a patient developed special memory loss, and his ability to navigate has been lost. What is the most likely structure involved? Can anyone answer?
Yes, server.
Fornix.
Not correct. Not correct. It is basically the mammillary body. When the mammillary body is responsible for the spatial memory, that is the ability of a person to remember things in relation to the others. Okay, the next one. After the removal of the third ventricular tumor, a patient has affected recall memory and named involved structure.
Ali, please.
Fornix.
Yes, fornix, body of the fornix. Correct. And the last one is the hypothalamic injury can present as A, disturbance in respiration, B, altered temperature control, C, hemiplegia, and D, both A and B.
Dr. Rajesh Pathi.
It can
Yes,
present with
Dr.
both
Rajesh.
A and B, sir.
Yes, correct. You are right.
And the other thing I would add to hypothalamic injury, which is often an issue after craniopharyngioma resection, is hypothalamic obesity. Yeah, so people can have altered satiety, and that can result in them becoming quite obese.
Okay.
Can you go back to the view of the posterior third ventricle?
So the posterior wall?
Yeah, and did you have endoscopic view of the posterior third ventricle or no?
No, sir.
Okay.
I have
show that one with the pineal region real quick. So the clinical context of is a little important as well. Like, when do we do these procedures? So you guys all know endoscopic third ventriculostomy can be tried in a variety of situations. We have a few minutes, right, Salman?
Yeah. We have time.
So endoscopic third ventriculostomy can be tried in cases of triventricular hydrocephalus, where the lateral and third ventricles are dilated and the fourth is not. You can also do, in order to confirm this, you can do a dye study. You can put a catheter in, give a little bit of contrast, and confirm the diagnosis that there's a disconnection between the third and fourth ventricle. And that can help you prognosticate and see whether or not this procedure is beneficial for the patient. Most often, patients are transitioning from a ventricular catheter to something more permanent, like either ETV or shunt. That's usually the decision. Should I put a shunt in this patient or should I do ETV? And this can be very helpful in selecting the appropriate patients, in my experience. It's not 100% because you can still have issues at the arachnoid granular level. So you can be kind of have a double whammy in the sense that there's a problem at the level of the aqueduct, the aqueduct of Sylvius, and as well as an issue at the granular level with a communicating component. So it doesn't mean necessarily that it's going to work. Post-ETV protocols, I think, vary quite widely. It'd be interesting to hear what Hasan says about how he does this, but I usually monitor pressures with keeping the EVD clamped for at least 2 days. If things look very good with regards to pressures, I also get an MRI. The MRI can be helpful. We can do, even if you don't have special abilities to do things like CSF flow analysis with a Zeta scan or something to actually look for flow, you can just do a T2 sequence and you can often see pulsation artifact or a or some black streak in that location on some of the flare sequences indicative of flow in that region. So that can also increase your confidence that the ETV has flow through it and is working. The last point is that just making a hole in the floor of the third ventricle is oftentimes not sufficient. The membrane of Liaquat and often also cause problems with CSF being able to egress out along the interpeduncular cistern. And so once you make the hole in the third ventricle, it's important to look through and look at the membrane of Liaquat and see, is there a significant membrane? Is there one that's easily reachable without much morbidity? And then make the opening there to complete the ETV. Hasan, what do you do for your post-ETV protocol? And Salman Bhai, what do you do?
So you know, when I first started out, I used to actually, well, I'll go back in training. We would do exactly what you were, you know, doing in terms of leaving an EVD in, clamping it, checking pressures, and hopefully taking it out. You know, I started to place Omaya reservoirs after an ETV and not place an EVD, as long as there wasn't any blood during the procedure, for 2 reasons. One, if there was any concerns if the ETV site was open or not, we could inject dye, as you talked about, to see if it's patent. And the second reason was sometimes patients would come from farther away, and if they presented with hydrocephalus, you know, to another hospital, they could quickly just tap the reservoir and take out CSF to relieve pressure. So typically I'll do that in pediatric patients. In adult patients, I tend to do what you described and what you do, where I leave an EVD and check pressures and things like that. Sometimes, you know, as you know, the ICPs can be high initially after surgery. So that's an observation, but clinically, if they're doing well, you know, I tend not to worry about that too much, and the pressures usually stabilize after a day or 2 anyway.
I'd asked Deopujari, please, if you could tell us what's your protocol for ETV. What do you do afterwards?
So if I'm doing a ETV for a posterior third ventricular tumor, or if I'm doing it for aqueduct stenosis, a straightforward indication, I usually do not keep anything. If I have been able to open the third ventricular floor well, as well as open the membrane of Liaquat well. If I have any doubts, especially in a post-hemorrhagic, post-infective hydrocephalus patient, if I am doing a ETV, I usually leave a Omaya reservoir behind. And these patients actually get 2 or 3 days consecutive lumbar punctures following surgery. And then we look to see if the patient develops any symptoms of raised pressure. We have not routinely kept ICP monitor on these patients, but if there is any doubt, I also do a dye study in these patients with the pre-existing reservoir.
Yeah, I think we have done the same, that we have stopped putting in EVDs routinely. We only do it when we are not sure, or if the pressure is very high due to one reason or other, or patient has a significant neurology, and you're worried that, you know, this patient should have a appropriate decompression, and we should have a check on it. That's the only time I'd leave the EVD behind. Yes, in some cases we have done lumbar punctures, but not as a routine. And we do not monitor pressure in these patients, and we haven't had any trouble. The important thing is post-op clinical examination has to be perfect, and the patient is then, you know, left in high dependency unit. So that's important for us.
Yeah, that's great. Yeah, and our pediatric colleagues do the same thing. Maybe I should be transitioning over to the Omaya as well. The other point I wanted to make is Dr. Deopujari just mentioned was that one of the more common reasons for doing this ETV is for posterior third ventricular tumors. And I'd also be interested in everyone's opinion, Hasan, Dr. Deopujari, and Salman, about how when you do this, very few people use the same incision and course through the brain in order to biopsy the posterior third ventricular tumor and do the ETV. The reason for not using the same incision or a hybrid is that oftentimes the traction that you need to apply to the fornix as you go through the foramen of Monroe is substantial when you try to split the difference. So what's better is to make two separate incisions. Even though you're going through the same foramen of Monroe, you're going to two completely different spots in the third ventricle, one to biopsy with a more shallow trajectory, and then one to do the ETV with a more steep trajectory. And I think it's very critical to optimize the trajectories for both of these.
I actually, if we get a chance, I have a video to show two cases where we can compare what should be done. But usually, I think it is decided by two factors as far as I am concerned. Factor number one, of course, is the size of ventricle. If you have a fairly large hydrocephalus and the dilated foramen of Monroe, you can probably manage quite well. One other thing which can bother you sometimes is with many a times with hydrocephalus, the interthalamic connection is not so very massive, and you can safely, slide your endoscope just underneath the massa intermedia, and you can go and get a biopsy. But if the massa intermedia is big and the ventricles are not too large, then I certainly prefer to have two boreholes. And we usually use navigation in such cases so that you can plan your trajectory. But the borehole is usually just at the hairline so that you can go even above the massa intermedia and take a biopsy directly from the posterior third ventricular lesion after you have performed ETV with the regular borehole.
In my experience, Azam, as you mentioned, I think the two-burrow technique is great if you have neuronavigation to plan trajectories. The optics of a rigid scope are great as well. I've also done the same ETV and biopsies with a flexible scope, much easier to do with the single burrow technique. However, the optics aren't as great as a rigid scope. So, it just depends on, how large the ventricles are and what the anatomy is specifically of the lesion in the posterior third ventricle.
Yeah, I agree. I think the most important thing for me is using the image guidance. And if you have the image guidance and you see where the lesion is, and if the lesion is reachable via the same burrow and it's safe, and as you said, if the foramen is big enough, then you do that. But if you clearly see that, your entry site for ETV and it's for going towards the tumor is completely different, then it's a problem. I think the trick that I learned from Henry is that he rotates the scope completely around, and once you do that, I think the vision opens up as well, and you're able to see posteriorly much better. You obviously can see much better, but can you take away all the tumor? That's the question. Biopsying is probably possible, but I think taking out a tumor like that is very, very difficult. You need to be really expert in this. And we'll just, okay, I think I muted Rafay because there is somebody in the background who's making noise, Rafay. Whoever is in the room, can you ask them to leave or stop making noise, please?
Okay, sir.
Sorry, Rajesh has a question, so we'll just take that question first. Yes, Rajesh.
Anatomy related question, sir. I just want to know the differences between what does velum interposum mean, and what is it different from thylakoidea and stria medullaris thalami, sir?
So I think it comes down to when we look at anatomy, we look at it based on the gross anatomy, the microsurgical anatomy, embryologic anatomy. So depending on how you look at anatomy, you call things different things, So for instance, the pons, there's a tegmentum and a tectum to the pons. the ventral and dorsal pons. You know, these are sort of surface anatomical landmarks. And they have, obviously they have things that underlie them, the microsurgical portion that's important as well, that relates to that gross, that surface anatomy. So when we talk about the velum interpositum in the tinea choroidea, tinea fornicis, tinea thalami. So these are sort of more microsurgical nuances. The velum interpositum is the area that contains these tinea, the veins, the arteries that course in this region. The tinea is a specific different area where you have a thalamic side and a fornicele side, sort of the attachment of the choroid plexus to the arachnoid is sort of the way that I think about it. Be interested to see what others think.
Yeah, I agree.
Yes.
There's a question that the symptoms that you describe for hypothalamic lesion can be seen after an ETV. Chandra?
I think it's, yeah, sorry. Please, Dr. Deopujari.
Sorry, I didn't get the question properly. What happens with the hypothalamic injury?
No, the question is, does the symptoms that you described for hypothalamic lesion could be seen after an ETV?
Well, I think hypothalamic injury you can diagnose fairly quickly during the procedure because there's usually some hemodynamic disturbance. And if it is really severe, you can in fact get a pulmonary edema even when the patient is under anesthesia and being controlled ventilated. So you can get the severe form of injury almost immediately. Milder injury, I think you will probably not get, but it might manifest in the form of electrolyte disturbance in the immediate postoperative time and in a delayed postoperative time, like Azam was saying, in a what is called premorbid obesity or hypothalamic obesity.
There was another question just about clinical follow-up in terms of post-op imaging as well. Do you have a routine that you all use?
Routine imaging, we do immediate, the 24 hours after the ETV, we usually do a CT scan, but this is mainly to see that if we have caused any hemorrhage, if there has been any complication which was probably not anticipated, but we should not be caught unawares. But otherwise, I think to see the patency of the ETV, I usually do a cine MRI at about 8 to 12 weeks.
Yeah, I think I would not do a routine scan follow-up the next day at all, unless I'm worried about something and unless it's a tumor or whatever, or if we have performed any other surgery. But for ETV, I think the average time that I do is follow-up scan is 3 months.
Yeah.
Because we know that not much would have changed within a week or a month or so. So we know that. There's a question from Carlos. Carlos, where are you from? And if you could ask your question, please. Carlos, can you hear us? So anyway, Carlos, we're going to lower the hand and mute as well. Azam, do you want to ask more questions that are there, or shall we move on and then we can come back to it?
I think we can move on.
Okay, let's move on.
I can't think of anything else.
And then we just unmute Rafay, and please, let's see. Thank you. Okay. Rafay, you can carry on, please.
Yes, sir.
Do you want to ask more questions, or are you done with your questions?
No, sir, I have done with the questions. Yes, I have done.
Are there any other questions?
No, sir, I have done with the questions.
Okay.
Is your presentation done? Finished?
Yes, yes, sir.
Okay.
Good. Very good.
So I have another question here. Azam, do you want to take that, please?
I didn't.
Parvat Kumar wants to ask something. Yes, please.
Yes, sir, actually, I didn't clear that when your follow-up CT scan of after ETV, it is 3 months or 24 hours after.
We just said that obviously it's debatable, but the benefit of a routine ETV, you're not going to see any change for 3 months or so, or at least 2 months. So some people do that, do a scan 24 hours, but if you have facility and patient is affording, or whichever hospital you're in, it's okay. But if you're doing it for a third ventriculostomy, then you're not going to see the ventricles go down. If you're concerned in any way, then obviously you can do specific sequences looking for if the flow is there or not. I usually do that only when I'm concerned. Any more questions?
Very nice presentation. That was really well illustrated and well prepared.
Thank you, sir.
Great.
Okay, so there is another question. Will you still leave EVD even though your stoma is large enough? Because I don't leave it. I can't answer this for people who leave it.
I think only in situations where there was some bleeding potentially would I leave it. Otherwise, I would not.
Okay, there is Larry from Uganda. He's asking, is it possible that you can show me the blood supply to the telacoridea?
So this is basically the slide that shows the vascular layer within the telacoridea, and this pile membrane. There are twofold of this membrane that form the telacoridea, and in between these layers there is a triangular space that is the velum interpositum, and it's important that it contains the vascular layer, the artery, and the vein. The artery is the medial posterior choroidal artery, and it contains the internal cerebral vein that receives the drainage from the septal as well as the thalamostriate vein.
Okay, good. There is a question from Eliminum, and he's asking, is transcallosal transformal approach for craniopharyngiomas? And this is for Chandra. Would you sacrifice the septal vein?
I'm very reluctant to sacrifice the septal vein, and I think intraventricular approach to a craniopharyngoma, I would specifically do if you are thinking of doing a radical surgery, only if you are dealing with what is called type 4 or a purely intraventricular craniopharyngoma, which is a rarity. In our about 134 cases, we have 8 cases of intraventricular craniopharyngoma, some of which I initially tried transcallosal. Nowadays, I do mainly transcortical endoscopic or endoscope assisted excisions. Most of the times I approach the cyst to decompress by endoscopic method, and then I go for radical surgery either by transcranial or transsphenoidal way, depending on the general morphology of the sella and rest of the tumor and the hormonal status of the patient.
Yeah, I think, Chandra, what's also happened is that we've started using tubular retractors like Vicor and stuff to approach this, either transcortical or transcallosal. And we found that because of that, you can use bimanual without running into any trouble.
Absolutely.
And able to do much better clearance.
Yeah, you described the syringe retractor recently in your use.
So basically what we do is we take a simple 3cc syringe or 5cc syringe, depending on how big or vascular the lesion is. And we just cut the end of the plunger itself and then we put the stellate inside and introduce that. And with the help of that, it's really cheap. It's like 10 rupiah, which is like a couple of cents. So I think because of that, it's really, really cheap, and it's you can make it yourself. We have written that in World Neurosurgery how to make that even, and so it is very, very simple.
I think the other reason why, I mean, early part of our career, most of us, I mean, I certainly did my first more than 25 colloid cysts with transcallosal approach. And we have all shifted to transcortical approaches because I think the risk of epilepsy we have seen, the difference between the transcortical and transcallosal approach is not as high as to, decide the transcallosal approach per se. The second reason, of course, is that I think I would use transcallosal approach if I am dealing with a colloid cyst which is a little unusual in location and there is no hydrocephalus. Then I would probably use a transcallosal approach.
Okay. There's a question: what happens in case of a thalamostriate vein injury? Azam, you've discussed this in our last session as well. Would you like to take this, please?
Yeah, I mean, you have to stop the bleeding. There's no getting around it, unfortunately. So I think avulsion injuries are a much bigger deal than peripheral injuries. And hopefully you don't have an avulsion injury because that can result in massive hemorrhage from the basilar. So in this situation, thankfully I've never encountered this, but you have to figure out a way to stop the bleeding. And if you can do that endoscopically, that's great. With bipolar is the best way, I think, of handling that. Before that, I guess the more important thing is to assess, is it a small branch coming off of it? Can irrigation alone help you in allowing the bleeding to stop just through either irrigation? Hasan mentioned previously this technique of evacuating all the fluid from the ventricular system in order to help with the bleeding as well. Again, I never had to do that, but these are all useful techniques and strategies when you have uncontrolled bleeding. But the first is to kind of assess the situation and make sure that you understand where the bleeding is coming from and not assume one thing or the other, and obviously not to panic.
Okay, I think that dry field technique was written up by Joachim Orotel, our friend, and Henry. Right. And they have recently written up their experience jointly on the cases that they've done, and they've shown very well that everything works really good. There's another question that is there a posterior approach of the third ventricle where is the route to enter into the third ventricle from posteriorly?
Dr. Deopujari, do you want to take that one?
I didn't get the question. I was
posterior third
is a bit
posterior third ventricular approaches.
What approaches would you take? I think today it would depend on what I'm suspecting. If I think that I'm dealing with either something which could be either a germinoma or which could be pineal malignant tumor, my approach would mainly be to do a ETV and take a biopsy before I consider doing any kind of major surgery. If I am dealing with a lesion which could be reasonably benign and the ventricles are not dilated, my current favorite is to do a supracerebellar infratentorial approach if the anatomy is reasonably favorable. And if it is more one-sided, then I am equally comfortable doing occipital transtentorial. So these are the three main approaches I use for dealing lesions in this area.
Okay, we'll take. Yeah, sorry.
There's there are the ventral anterior approaches and then the posterior approaches. And so the anterior approaches go through the third ventricle and use some combination of either transforaminal or transchoroidal, more commonly transchoroidal approach to the posterior third ventricle with more of an anterior to posterior trajectory. The trajectory tends to be quite long when you do it this way for those pathologies located in the very posterior part of the third ventricle. Dr. Deopujari has mentioned the more common germinoma. Obviously, that's not necessarily a surgical disease. But there's other rare tumors like papillary tumor of the pineal. We've actually had a couple of, I think 5 cases of this rare tumor here in the past 7 years or so. So maybe not quite as rare as we would think. Ependymomas would be another possibility, subependymoma. So these would be more likely handled potentially with a ventral approach. Maybe thalamic tumors that are protruding into the third ventricle or cavernomas. Posteriorly, especially the posterior paramedian approach is supracerebellar, infratentorial, or transtentorial, depending on the angulation of the tentorium. As Hasan mentioned in one of his slides, I believe, is a really great way to approach it from posteriorly. I think the posterior midline approach, even though oftentimes people talk about posterior midline, because of the veins that you need to take, and people always talk about taking precentral cerebellar vein. My only issue with taking that, while it can be taken, is that, and it may also be helpful for relaxing the cerebellum and allowing it to kind of relax downward and opening that view, is that you can end up with bleeding depending on how much of a stump you've left on the galenic side, and so that you want to leave a very nice stump and not take it too close to galen, otherwise you can end up with bleeding from the vein there, which would not be good. So I prefer the paramedian approach. I think the window tends to be usually quite comfortable to work through.
There was one question about the Omaya reservoir. Dr. Deopujari, do you leave it in or do you ever take it out?
I keep the Omaya reservoir usually till I know that my CSF diversion procedure is MRI at 3 months, and that is the time I give them the option of taking them out. About 50% people get it out, other ones don't bother.
Yeah, I think once it's in, usually in my experience, patients are okay with it.
Okay, I think Professor Deopujari has a couple of cases to show, so he's just going to get his cases booted in his computer while we can continue to discuss. If in a smaller foramen of Monroe, what do you guys do for your ETVs where the foramen Monroe is really small? I've seen Henry trying to dilate the foramen. I don't know what you guys think about it with the Fogarty catheter.
Yeah, I haven't had to do that, but I've talked to senior surgeons who have done that, and I think that's an option. The other thing is, as I mentioned, the flexible scope is a much smaller scope, and that can be an option as well.
Yeah, I would prefer to open further posteriorly to the venous angle in an intentional way. I'm not saying that dilating it is wrong, but I always worry about traction on the fornix. You can obviously apply your traction different ways, depending on how you apply it. You may put the fornix at less or more risk, but I think that selecting the side to pick that venous angle so that you can open things up is, I think, important.
Yeah, the other thing we noticed, what we used to do is, you read in the books that when you do ETV, you just go bang on the coronal suture, or in many books it says 1 centimeter in front of the coronal suture. So what we did was we started measuring exactly where the best entry point could be, and using the image guidance. And over time, we realized majority of the time it is behind the coronal suture in adults. And because of, and then we wrote this up and showed that people we, for example, we did measure in one person, and we started to operate, and the resident made a burr hole exactly on the coronal suture instead of a centimeter behind, although the incision was there, the target was there. And once we were in, we noticed, I said, how is that possible? When we looked in with the image guidance, obviously we were a centimeter in front. And we did make a small contusion on the fornix. So small contusions you can get away in majority of the time, but there's no need for that. So I think if you have image guidance and you're doing ETV, it's important that you use that and make sure your entry point is at the perfect place. Sometimes I've had the entry point 2 centimeters behind, but behind the coronal suture, and that's probably going into a dangerous territory, and you may be causing problems. And that's why then you say that maybe 1.5 centimeter from coronal suture is generally pretty all right. And it doesn't give any problems at all. And as long as the foramen Monroe is big enough, I think you should be able to get in there. Okay, I have a question from Parvat Kumar. Yes, Parvat. Hello? Parvat, can you hear me?
Sir, hello. Hello.
Yes, you want to ask a question?
Yeah, sir. My question is, I can't understand that posterior approach for this third ventricle. Please again explain, please, sir. My question to posterior approach. Hello.
Sorry. Can you ask that question again? I can't hear you.
I say that, sir, we are proceeding through the foramen Monroe in anterior approach, and some question someone raised that posterior approach. I can't hear that properly. The posterior approach to this.
So Professor Deopujari talked about 3 different approaches coming from behind when you're trying to come into the posterior part of the third ventricle. Azam, you want to take it away and just tell us about the 3 different approaches that we discussed there?
Yeah, so I mean, you can go through you can take a more anterior to posterior trajectory, and you can go through the telecoroidea is the more common way, a transchoroidal approach, in order to get to the posterior third ventricle from anterior to posterior, or you can go from posterior approaches, the most common being supracerebellar, infratentorial, or transtentorial would be the most common ways. Less common would be to do something like a posterior interhemispheric. That would be unusual unless the pathology was something that didn't initially start out in the pineal region and extended downward towards it. But in general, supracerebellar, infratentorial, or transtentorial, depending on the angulation of the tentorium.
So Azam, if you had a tumor which was extending in front and going up at least 1.5 centimeter anteriorly from a pineal tumor, would you approach it endoscopic anteriorly?
Yeah, I think I always, as Dr. Deopujari mentioned, I always do a biopsy first to make sure that it's something that should be resected. If so, I really liked the transchoroidal approach. I think that it gives you the sort of a widest corridor. Even though the trajectory is a little bit longer, you have a wider corridor to get there. And so I think if something is extending anteriorly and the long axis is favorable for that, then that's what I would take. The long axis of the tumor is more favorable for a posterior approach, then I would do that instead. So I think this concept of the long axis of the tumor is really, really important, because not necessarily is it that most tumors tend not to be perfectly spherical. They tend to have a bit of a long axis, and that the face that presents itself to you and that long axis are often helpful in deciding what approach you should use when other things are equal.
Right, Professor Deopujari is back. Chandra, you want to share your slides? Are you ready?
Yeah. So do you want me to show a couple of cases maybe?
Yes, please. We talked about the biopsy. How do you decide single burr hole or 2 burr holes?
Yeah. So basically, I think when we are looking at endoscopic biopsy of a posterior third ventricular lesion, you are going to usually put an anterior burr hole 4 to 6 centimeters pre-coronal to get directly to the tumor, if that is your only objective. And neuronavigation usually will give you a good kind of orientation as to what should be your trajectory to go there, as you would find in this picture. If you want to combine it with endoscopic third ventriculostomy, and I think most of the times you choose endoscopic biopsy in patients who have larger ventricles and who require a CSF diversion procedure, then usually you do a burr hole about 2 to 3 centimeters in the sagittal plane in the mid pupillary line, and that usually suffices if the foramen of Monro is large enough to do both. We'll just see an example. So this is a posterior third ventricular tumor which is presented with hydrocephalus, and you can see that we have entered into the ventricle, and we are making a third ventriculostomy. The floor is almost opalescent, so you are going as close to the dorsum cellae as possible. As I told you that apart from navigation, I think it is a very good tactile navigation to feel that, and then you are usually in this. And then if you turn your scope posteriorly, you can immediately find you are going below the massa intermedia, and you can take a biopsy. And this patient already had actually a shunt which was malfunctioning. So we took it out of the wall and then pulled out this catheter later on. So you can safely do a biopsy. This turned out to be a pilocytic astrocytoma. So we actually went further second time by an infratentorial supracerebellar approach and removed this lesion. These are the usual pictures, and this is how you can take a biopsy. Earlier, I used to say that you should use a 30-degree scope for biopsy because you get a better angle onto the tumor, a more sort of end-on view rather than getting a side view, and therefore you usually find in the beginning when you have not done many cases, you find that your forceps will usually slip down and you cannot catch a biopsy, and therefore using a 30-degree scope during biopsy works well. However, I think with experience you can do it with a 0-degree scope. I would show another case, where again we have a third ventricular tumor. You can see the ventricles are not so large in this particular patient, and I have done a third ventriculostomy already. And the foramen, not only the foramen of Monro is not very large, but more importantly, the massa intermedia is quite big. So I had to actually make another burr hole, and I'll show it to you on the video. So this is where we have a slightly enlarged ventricle, not too much enlarged foramen of Monro, and we are going for a third ventriculostomy here. And I think you have seen enough third ventriculostomies. So the third ventriculostomy has been completed, and you can actually see some perforators. And then I'm made a little posterior opening. So I made an anterior opening and again dilated it. So I got a proper perforation there. And then I am trying to go back the same way as I did in the earlier patient. Something is not working, but it was not possible to visualize. No. So then I had to go above the, somehow the video is not working for me. So I had to go above this with a burr hole, which is just below the hairline. And then I can go directly and take a biopsy in this patient. This turned out to be a malignant pineal tumor. And this patient CSF also showed some dissemination. So this patient was subjected to radiation and chemotherapy. So these are the two ways you can actually tackle it, and you can many a times plan that with the size of the ventricle. And as Salman also said, that we should use a navigation while doing these kind of biopsies with a. So two technical points apart from the size of the ventricle and the size of the massa intermedia. The third question comes, is ETV first or biopsy first? We prefer to do ETV first, as biopsy related bleeding may obscure the view later. But there are people who believe that maybe the chances of dissemination increase, etc., and we should probably do a biopsy first. So I would like to know views of Hasan and Azam on this. Thanks.
Thank you, Chandra. I think that was brilliant. We would do exactly what you would do. So you would do an ETV first, and because you want to be seeing everything clearly, and then do a biopsy. Yes, that small worry is there, but that worry is very small. And if for whatever reason, it bled and you could not do an ETV, then you wouldn't have done the job. The job would be undone. So there's no point in doing that. Azam, do you agree?
Yeah, actually, I do the opposite. I'm surprised because I take the opposite view. I worry that the ventricles will collapse a little bit after the ETV is done. Maybe that's an unrealistic worry, but that's what I've done. Maybe I should be doing something different. I've not encountered a situation yet.
Or you haven't done it at all?
No, I have. I've done it. I've done plenty of third ventricular tumors with ETV, but I've not had a situation where I've had, bleeding to the point where I wasn't able to see the anatomy of the anterior floor of the third ventricle. So I tend to do it in the reverse order, but your points are well taken. Maybe I will switch. Maybe my concern is unrealistic of, or not so significant of the ventricles collapsing and obscuring the view of the posterior third ventricle.
Yeah, I think what I did was I learned this in Birmingham, and Tony Hockley used to be there, and Spiros trained with me as well. So we both were together there, and over time we realized that there's a big series out of there which showed that by doing that they were pretty all right, and the results were pretty reasonable. Chandra, there's a question about pediatric pineal tumors. Again, do you think you can?
We should ask Hasan. What does Hasan do?
Hasan, Hasan is not here. He has a case to do, so he left early. Sorry.
Okay. Hasan would have agreed with me. I'm just kidding.
Pineal tumor, a kid, hydrocephalus, endoscopic approach. Can you use the same endoscopic approach? Same question.
Yes, I think especially in children, pineal region tumors, you must be very, very careful about possibility of a germinoma. And I would first do a serum tumor markers, and then only proceed. If serum tumor markers are positive, I can even avoid that unless the patient needs surgery for hydrocephalus by itself, in which case, again, I think my preference is ETV, because you can also take a biopsy at the same time. And, some mixed tumors can probably be missed while doing just serum tumor markers. So we get an additional possibility of getting a CSF tumor markers and also get a biopsy.
Have you had good response with CSF tumor markers? Because we haven't, I don't know.
No, we have 2 labs in the city which are fairly reliable, and we rely on the CSF tumor markers much more actually.
Okay. Anything else, Azam, or shall we wrap up? Are we done?
I have to head to the OR anyway, so unfortunately. This has been great, though.
No, we all enjoyed it. I think it's a good discussion. Imad, can you please share the screen and show what we have for next couple of days? So tomorrow we have Richard Asakar from Lille and Giovanni from Palmero. We have from Italy, and Mehmet is the moderator, and we're talking about thoracic disc and hybrid surgery. Actually, Richard wanted to talk about OLIF for whatever the reason. Imad gave him this thoracic disc, so he has to do it now since he put the poster out. Then we have IFNE, WFNS Endoscopy Committee weekend update. And so compared to what the talk we had yesterday with all about craniotomy for craniopharyngiomas, we're going to be discussing 3 different approaches by three excellent surgeons. And Chandra is going to discuss a case, and then we're going to follow up with these three different approaches. One is a mixed approach, endoscopic assisted transcranial, then endoscopic endonasal, and then endoscopic intraventricular approach. So it's going to be what type of tumor you're going to address that. And we have that on Saturday. And then, Ahmad, have you got something else for us? Not yet. Okay, no worries. You have something? Hello?
No, sir. I only have scheduled.
Okay, so show us the schedule, what you have.
Great. Have a busy weekend.
You will be there on Saturday, Chandra, so don't worry.
Yes, yes. See you.
So if we see here, we have, so I have any update with Pepe, Sergey, Luigi, and Chandra. And then we have Sunday with Future of Neurosurgery. So all the ladies, so we have Sandy Lime, Anila Darbar, Najia from Morocco, and Abida from Bombay will be giving talks. And this is Women in Neurosurgery. Monday, we have Rick Fester talking about, I think he's talking about, if I'm correct, cervical spine difficult complex cases, complex surgery, not OLIF. Maurizio, who's also the chair of WFNS Spine with us, is going to be talking about something, I don't know his topic. On Wednesday, we have Adrian and Ramesh. They're going to be talking about meningioma excision, endoscopy principles, and how to stay out of trouble. Thursday, we have, where did it go? So we have yourself. So anatomy, we're going to be doing fourth ventricle. So the fourth session of this first module on anatomy of ventricles, we're going to finish on Thursday. Friday, we have Hasan in STEM on Saturday the 23rd. We won't go into what we have for you in future. So I'm grateful. Thank you, everybody. Thank you, Chandra, Azam. It was a pleasure having you all.
Thank
Any
you very
comments?
much.
Really enjoyed that. Thanks a lot. Bye-bye. And we'll see you tomorrow or day after.